Welcome to this explainer on Chapter 463, Psychiatric Disorders. We're taking a systems-based, postgraduate level approach today, bridging the gap from broad clinical observation all the way down to advanced neurobiology. If you've ever wanted to understand how modern psychiatry connects behavioral syndromes directly to the complex architecture of the human brain, you are absolutely in the right place. Here's our roadmap for today. First up, clinical classification, then depressive and bipolar mood disorders, followed by anxiety and trauma-related frameworks, and we'll wrap up with advanced neuropsychopharmacology. All right, part 1, clinical classification and the diagnostic paradigm. Let's get right into it. To really wrap our heads around the massive global burden we're talking about, take a look at this number. 300 million. Mental and substance use disorders are literally the major cause of life years lost to disability across all medical illnesses, affecting over 300 million individuals worldwide. So, this isn't some niche subspecialty. It is a massive global health priority that touches countless lives. And just look at the biological weight of these conditions. Genetic risk actually makes up anywhere between 20 and 90% of an individual's vulnerability to psychiatric disorders across the board. These are highly heritable central nervous system diseases. They're wired right into our biology. But here's the clinical paradox we face, right? Because we currently lack bona fide, definitive biological markers for these super heterogeneous syndromes. Everyday clinical practice still relies almost entirely on the diagnostic paradigms established by the DSM-5. We're essentially treating biologically driven diseases based predominantly on observational clinical criteria from the American Psychiatric Association. Moving on to part 2, depressive and bipolar mood disorders. So under the DSM-5, a major depressive episode is way more than just feeling down for a few days. It requires a minimum duration of at least 2 weeks. And this has to be characterized by a profound loss of pleasure, what we call anhedonia, or a depressed mood. But you also need at least 5 total symptoms present. We're talking significant neurovegetative stuff here. Major weight or appetite changes, insomnia or hypersomnia, totally debilitating fatigue, feelings of worthlessness, and recurrent thoughts of death or suicide. It's a total body syndrome. On the flip side, a manic episode needs a distinct 1-week period of an abnormally elevated, expansive, or even highly irritable mood. And what's really fascinating and honestly dangerous is the decreased need for sleep. We're not just talking about insomnia. These patients often feel completely rested after just a couple of hours. Combine that with racing thoughts, extreme grandiosity, and excessive involvement in high-risk activities, and you've got a very intense clinical picture. Now, here is an absolutely crucial clinical pearl. You have to correctly differentiate a bipolar diathesis from unipolar major depression. Why does this matter so much? Because prescribing standard antidepressants to a patient with underlying bipolar disorder can actually be totally contraindicated. You could inadvertently worsen their symptoms and drastically accelerate their mood cycling. Definitely not what we want. Thanks to modern imaging, we can actually see the neural circuitry of mood within the limbic system. It's incredible. Brain imaging shows us that a subset of depressed individuals actually exhibits a physical reduction in the size of their hippocampus, right alongside increased amygdala activation when they're exposed to negative stimuli. We can quite literally see the physical footprint of depression in the brain's architecture. Zooming in even closer to the cellular signaling adaptations, severe depression is heavily characterized by HPA axis hyperactivity. This means the body is just pumping out increased cortisol and corticotropin-releasing hormone, which theoretically can cause atrophy in those exact hippocampal neurons we just looked at. We also see dexamethasone non-suppression, pointing to a profound failure of the body's natural stress regulation feedback loop. But it doesn't stop at the neck. Beyond the brain, the biology of mood disorders is highly systemic. We can measure elevated levels of pro-inflammatory cytokines like IL-6 and TNF-alpha right in the blood. We see oxidative stress, mitochondrial dysfunction, and perhaps most surprisingly, premature cellular aging, which we can actually see through measurable telomere shortening. Plus, we've even got altered gut microbiomes in the mix. The entire biological system is under siege. All right, on to part 3, anxiety and trauma-related frameworks. Let's start with generalized anxiety disorder, or GAD. This presents as persistent, excessive, and unrealistic worry over everyday matters. Patients are quite literally on edge, dealing with prominent muscle tension, impaired concentration, restlessness, autonomic arousal, and insomnia. When we look at the pathophysiology,
This syndrome heavily implicates the GABA A receptor and chloride ion channel complex, which is what regulates inhibitory signaling in the brain.
PTSD, in stark contrast, requires exposure to extreme traumatic events, actual or threatened death, injury, or violence. This triggers intense hypervigilance, an exaggerated startle response, intrusive flashbacks, and profound avoidance of traumatic stimuli. Theoretically, this fear-based memory encoding is fueled by a massive release of norepinephrine from a brainstem structure called the locus coeruleus, which then projects powerfully to the amygdala. So when you compare the two, it becomes really clear why the continuous, generalized worry and muscle tension of GAD demands a very different clinical management strategy than the acute, cue-triggered sympathetic hyperarousal we observe in PTSD following a specific extreme trauma.
Which brings us to Part 4, Advanced Neuropsychopharmacology and Treatment Selection.
Looking at the SSRIs, it's not a one-size-fits-all situation. Clinicians have to play matchmaker. For instance, fluoxetine is often chosen because it has a very long half-life, which is great for one's daily dosing. Sertraline is highly favored for patients where you want a lower risk of adverse drug interactions. But then you have paroxetine, which is more anticholinergic and carries a notably higher risk of withdrawal symptoms if it's stopped abruptly. But we have to be careful. When using these serotonergic agents, you absolutely must be vigilant for serotonin syndrome. This is a dangerous, potentially fatal complication caused by the hyperstimulation of brainstem 5-HT1A receptors. Patients can present with sudden severe agitation, myoclonus, hyperreflexia, and heavy diaphoresis, or sweating. It's a prime example of why precision dosing matters. For anxiety treatment, we've got a classic trade-off. Benzodiazepines like diazepam and triazolam act directly on those GABA A receptors to provide incredibly rapid relief. But they carry massive risks of tolerance, cognitive impairment, and high abuse potential. On the flip side, you have non-benzodiazepine anxiolytics like buspirone. It's a non-sedating, partial 5-HT1A agonist. No tolerance, virtually zero abuse risk. But the catch? It requires weeks of daily dosing to build up clinical efficacy. Moving over to schizophrenia treatment, pharmacology has seen a massive evolutionary shift. Older, conventional neuroleptics relied on a really strong D2 receptor blockade, which unfortunately caused high rates of severe extrapyramidal motor side effects. The newer atypical agents, like clozapine, risperidone, olanzapine, and paliperidone, shift their affinity. They focus more on D4 and 5-HT2 blockade over D2. The result? Much lower motor side effects, but you trade them for complex metabolic risks, like significant weight gain. Speaking of side effects, we have to define akathisia. This is a deeply debilitating inner sense of restlessness and anxiety. Patients feel like they literally cannot stop moving. It's a very common adverse effect early on in SSRI treatment, and it's notably prevalent with certain high-potency antipsychotics. It's a critical clinical indicator that the synapse is reacting strongly to our intervention. Which leaves us with a massive question to ponder. If a patient's psychiatric disorder has up to a 90% heritable diet thesis rooted in highly specific limbic circuitry and receptor affinities, how soon will the next generation of precision psychiatry move beyond the symptom-based observational checklists of the DSM-5? When will we actually be able to directly target and truly cure the complex architecture of the synapse itself? It's a thrilling frontier. Thank you for joining me on this explainer, and I hope it left you with some fascinating new perspectives on the neurobiology of mental health.